Hello. I want to thank you guys for having me here at TOBI to speak. I'm really excited about talking today. Today, we're going to talk to you about the quantification differences between bone marrow aspirate and bone marrow concentrate. I have no disclosures. So why bone marrow? So bone marrow has been used in regenerative medicine for numerous years for numerous musculoskeletal conditions. We know that bone marrow contains MSCs, medicinal signaling cells or mesenchymal stem cells, HSCs, platelets, and growth factors. But the problem is when we actually look at the concentration of MSCs in a bone marrow aspirate, it only makes up about 0.001 to 0.01% of the bone marrow aspirate. So we find that when we can concentrate bone marrow, we can get a higher number of the MSCs that we want to put in our injectate. So when we look at how do we ascertain the bone marrow, not all bone marrow aspirate kits are equal. So we have our classic Jamshidi needle over here to the left, the green one. We have our Marrow Solutions needle over there, the dark blue to the right, and then our Aspire needle to the left. Historically, most people used a classic Jamshidi needle. Jamshidi needle has a trocar that's sharp and allows you to break through the cortex of the iliac crest. And then once you're through the cortex, you remove that needle, and then you're able to aspirate. The first 1 to 2 mLs is going to have a high number of MSCs. But then after that, you're going to get a large rush of peripheral blood that's going to come from the bottom port that's not blocked. So Marrow Solutions came out with a unique kit that allows you to lock that bottom port to prevent the peripheral blood from being aspirated through that port, and then to do the aspirations through the side ports. And so as you can see at the bottom picture, you can start very low down in the iliac crest, and then you can aspirate from the side ports, not aspirating from the peripheral blood from the bottom. And this allows you to get at different levels, MSCs, as you kind of slowly start to retract your needle. So I went to see what was the data out there to kind of support this. So Dr. Scarpone published a paper, and he came out stating that he could isolate clinically relevant concentrations of bone marrow MSCs without centrifugation. I thought this was great. As a clinician, this is something that I can do quick, easy, and not have to spend the extra time of concentrating. And they concluded that they were able to get CFU counts, CD34 counts, CD117 counts that were comparable to other BMAC devices. As we kind of drilled down a little bit more, I saw that the study used 3 different global laboratories for their MSC determination. So there was really no uniform standard. It was a very small sample size for all 3 comparisons, and there was no information on other important constituents, such as platelets. And then they didn't talk about the effect of RBCs. And when they compared things, they didn't compare it using instructions for use. So it really wasn't an apples to apples comparison comparing their marrow solution to 60 mLs for bone marrow concentrate. So Aspire came out with a needle that was similar to the Marrow Solutions needle, where they blocked the bottom port with a blunt tip and still did the aspiration from the side ports. But instead of stopping at just 10 mLs like the Marrow Solutions kit, it allows you to get another 50 mLs, so a much higher number, and then you can still concentrate that. And so why do we want to concentrate? We find that with concentration, we can remove RBCs and we can decrease the amount of the hematocrit, but we can also concentrate the number of MSCs. And this also allows you to produce a final concentration volume between 10 to 14 mLs. So what's important about RBCs? Why do we want to minimize our RBCs? Well, Dr. Everts published a nice review paper that looked at how RBCs affect our injectate in regenerative medicine. And what he found is that high level of RBCs can cause hemolysis. This hemolysis is highly oxidative and highly inflammatory. There's also good data to support that RBC content has been shown to be chondrotoxic. So this is something that I don't want to put in if I'm treating for osteoarthritis. So this image here shows that when you have erythrocytes in your injectate, you're going to break down in 1 to 2 pathways. If you go to the pathway to the right, it goes through eryptosis, which can lead to a high amount of inflammation And also it can impede microcirculation, things I don't want. I want to increase circulation in my regenerative injection. If we go to the left, it goes through hemolysis. And once it goes through hemolysis, that releases the MIF protein. And that can cause a profound amount of inflammation. Once again, things I don't want to happen with my injectate. So we did a study design to compare the Marrow Solutions kit versus the Aspire kit. Here's our study design. We had patients between the ages of 40 and 65, no NSAIDs within 2 weeks, no cortisone within 6 weeks, no anticoagulation, no immunosuppressive medications, and no active systemic infection or malignancy. The comparison that we did, we had 12 patients done at 4 different institutions with 4 separate providers. Each patient had 1 iliac crest harvested with Marrow Solutions, the other one with the Aspire needle. We sent off all of the results to the lab. It was an independent FDA GLP certified lab, and they tested platelets, RBC count, CFU count, CD34, and TNCs. So these are our 4 comparison groups. The first one is the Marrow Solutions. According to the instructions for use, they aspirate approximately 10 mLs at different levels of the iliac crest. Then we had the Aspire needle. We did a first 10 mLs so we could have an apples to apples comparison of the two. After that, we did the next 50 mLs through the Aspire needle. And then for the 4th group is the concentrate, where we took the first 10 mLs from the Aspire first group, and then the last 50 mLs, concentrated that, and put that through centrifugation. So here are our results. When we look at our platelet count, we find that the bone marrow concentrate group had a significant increased number of platelets compared to our Marrow Solutions, our Aspire group, and our BMA 60 group. When we look at our RBCs, our hematocrit, these are the things that we're trying to minimize. We found a significant decrease in our bone marrow concentrate group of both our RBCs compared to all 3 groups of the Marrow Solutions, Aspire, and BMA, as well as a significant decrease in the hematocrit compared to all 3 groups also. Now let's look at our MSC count. These are our CFUs. When we look at our concentrate group, our bone marrow concentrate group, there's a significant increase in the number of BMCs compared to the Marrow Solutions group. But even looking at the Marrow Solutions first 10 mLs to the Aspire, the AS first 10 mLs, there's a significant increase in the number of MSCs there. Then when we look at our CD34 group, there's a significant increase in the number of CD34s in our BMC group compared to our Marrow Solutions group. Once again, in our TNC group, we found a very similar thing, a significant increase in the number of TNCs in our bone marrow concentrate group compared to the Marrow Solution group. And then when we look at viability, there was no significant differences in viability across the 4 groups. So what are our takeaways? What are our conclusions? One is when we look at the first 10 mLs of both of the bone marrow aspirates, neither one were concentrated, we found that they performed equally well on the variables that we tested. But once we concentrated, we found that our Aspire concentrate group had a significant reduction in our hematocrit, as well as our RBCs compared to the pre-processed BMA from the Aspire. Also that it had a significant increase in the CFUs, the TNCs, CD34, and platelets compared to the Aspire BMA. Then when we compared our Aspire BMC to the Marrow Solutions BMA, there was a significantly higher amount of CFUs, TNCs, CD34, and platelets in our Aspire concentrated group. And then when we compare our Aspire concentrate group to the BMA as far as hematocrit, there was a 76% reduction in hematocrit in our concentrate group. That's a P.0001. And there was no significant difference in cell viability. So, long and short, when we're able to concentrate, we're able to increase the cells that we do want and decrease the cells that we don't want. Thank you.